Hello and welcome to JCO Article Insights. I'm your host, Ash Gurumurthi, and today we will be discussing an article published in the April 2026 issue of the Journal of Clinical Oncology. It's called Duvelisib Induces Deep Responses in Peripheral T-Cell Lymphoma. Final results of the phase 2 PRIMO trial evaluates Duvelisib in relapsed or refractory peripheral T-cell lymphoma. So we're going to be talking about relapsed and refractory mature T and NK cell neoplasms. These are a heterogeneous group of more than 30 types, accounting for 10 to 15% of all lymphomas, and they're classified according to their presentation. We're specifically going to focus on nodal peripheral T-cell lymphomas, or PTCL, which have a poor long-term survival with 5-year survival that approximates 50%, with lymphoma as the leading cause of death. After first-year relapse, median survival is only 6 to 12 months, and allogeneic stem cell transplant remains the only potential curative option in fit patients who achieve a response. Historically, there has been no standard of care for relapsed PTCL, except for brentuximab vedotin in CD30 positive disease. Novel agents like histone deacetylase inhibitors or HDAC inhibitors like romidepsin and belnestat, or antifolate agents like pralatrexate have worked, but they've only produced an overall response rate of 30% and CR rates of 10 to 15%. Duvelisib is an oral PI3K inhibitor targeting the gamma and delta isoforms. It was first approved in B-cell chronic lymphocytic leukemia with promising results in a phase 1 trial in relapsed PTCL. The PRIMO trial is a phase 2 multicenter open-label study with a dose optimization phase followed by a dose expansion. The primary endpoint was the independent review committee assessed overall response rate using Lugano 2014 criteria. The secondary endpoints were PFS, OS, duration of response, and safety. Based on early progression, when they used the lowest starting dose in the optimization phase, the expansion cohort received 75 milligrams twice daily for 2 cycles, followed by a lower dose of 25 milligrams twice daily to allow for disease control and reduction in late toxicities. The expansion phase enrolled 123 patients globally with a median age of 65 years and median of 2 prior lines of therapy. As we can see, this is a highly refractory population, and the overall response rate was quite impressive at 48% and 33% CR rate within the first 2 cycles. This is near doubling of the CR rate compared to the historical agents of HDAC inhibitors that we've spoken about. Although this study is not powered to assess differences in response between histological subtypes of PTCL, the responses were higher in angioimmunoblastic T-cell lymphoma, that is the AITL subgroup. Overall response rates in this group were 62%, and the CR rate was 51%. The responses for PTCL NOS subtype was similar to the entire cohort. Anaplastic large cell lymphoma had pretty poor responses. The time to event endpoints were consistent with response data. AITL patients, for example, had the longest duration of response at nearly 6 months, with the most favorable PFS and OS. Now, only 15% of patients had their survival data censored because they proceeded to transplant. This really means the duration of response that we're seeing is largely derived from patients who remained on study treatment. That 15% of patients who went to transplant had a 4-year survival of about 75%, confirming the effectiveness of using Duvelisib as a bridge. Let's move on now to talking a little bit about safety. From a safety perspective, Neutropenia was the most common hematologic toxicity. It occurred in a third of patients, with grade 3 or higher reported in 18%. Grade 3 or higher thrombocytopenia and anemia were pretty uncommon, occurring in single digit percentages. When we look at non hematologic toxicities, the most common grade 3 or higher events were liver transaminitis, occurring in nearly a quarter of patients. Grade 3 or higher infections occurred in 13%, with cutaneous reactions in 11% and diarrhea in 10%. One of the problems with PI3K inhibitors in other malignancies is well known to cause immune mediated adverse effects. So it was surprising to see that these were relatively uncommon in this trial. For example, colitis and pneumonitis occurred only in 2% of patients, respectively. For treatment related mortality, it was mainly due to infections and it occurred in 3% of patients. There was a single treatment related death from immune mediated pneumonitis. In terms of tolerability, this continued to remain a major problem. About a third of patients had to stop treatment permanently due to adverse events, and this was mainly due to liver test abnormalities followed by infections and diarrhea. So, Duvelisib is currently not FDA approved for PTCL, but it has been available through NCCN recommendations for relapsed or refractory disease, with its access maintained through its approval for chronic lymphocytic leukemia. Although the results from PRIMO are not necessarily practice changing because many clinicians are already using Duvelisib based on earlier data in relapsed PTCL. But these final results are providing us with a more complete understanding of the long term efficacy, the safety, and tolerability of Duvelisib. There is currently an ongoing confirmatory phase 3 trial in Europe called the TERZO trial that is comparing Duvelisib with chemotherapy, which is needed for regulatory approval in relapsed PTCL, which will give us more data. So I want to talk about where Duvelisib fits in the treatment of relapsed PTCL in the real world. Duvelisib clearly achieves greater responses than many historical novel agents, but ultimately Duvelisib shares some of the same limitations. For example, responses are not durable and tolerability remains a significant problem. All patients eventually discontinue treatment, most commonly because of disease progression in about 41%, and in the remaining, it was mainly due to adverse events. We can see this reflected by the PFS, which is quite modest at approximately 4 months for the overall cohort and 6 months in the AITL subgroup. In current clinical practice, the greatest value for Duvelisib appears to be in a role where we are bridging to transplantation. It can bring about rapid disease control within 2 cycles with high response rates, allowing eligible patients to proceed to curative therapy with stem cell transplantation rather than relying on prolonged single agent treatment. As clinical practice increasingly shifts to using Duvelisib as a bridge to transplantation, rather than using it indefinitely as a single agent, we need more studies to better define transplant eligibility, looking at transplant utilization and post transplant outcomes to better understand the real world clinical value of Duvelisib. I suspect for non transplant eligible candidates, combination therapy is likely to represent the future of Duvelisib. The Memorial Sloan Kettering Group has already demonstrated combining the HDAC inhibitor intravenous romidepsin with Duvelisib improved CR rates, particularly in AITL, while appearing to reduce high-grade transaminitis associated with Duvelisib. There are additional combinations with emerging oral agents like selective JAK1 and EZH2 inhibitors that appear attractive because they target complementary oncogenic pathways in PTCL and are very convenient for patients because they're an all oral regimen. So, from this trial and on the topic of relapsed PTCL, my take home messages from this trial are number one, the PRIMO final results of Duvelisib in relapsed refractory PTCL demonstrates high overall response rates and CR, particularly in the AITL subtype. Number two, tolerability remains a significant problem leading to treatment discontinuation, particularly due to hepatotoxicity and infections. Number 3, long-term incorporation of other novel inhibitors as a combination therapy with Duvelisib may enhance further responses. Thank you all for listening to JCO Article Insights. Please come back for more interviews and article summaries, and be sure to leave us a rating and review so others can find our show. For more podcasts and episodes from ASCO, please visit asco.org/podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.